This is local work done just in Oxfordshire, so looking at Oxford at the John Radcliffe Hospital and Banbury Hospital. And this was inspired by these types of results where we know that the MenB vaccine was associated with high rates of fever, and Shamus has done a great job laying the groundwork for that there, and talking about how paracetamol can reduce that risk of fever. Alongside this is this kind of dilemma that paediatricians have, and it's one of those things that everyone thinks is perfectly obvious, and then when you start to ask 10 paediatricians, they all have a different answer as to what they do when they see a child turning up to accident emergency with a fever post an immunisation, as to whether that's just fine, you could ignore the fever in a 2-month-old because they've had a vaccine, through to they need a full septic screen, just like any other 2-month-old who's had a vaccine, who's not had a vaccine. And in fact, the NICE guidelines for management of febrile children make no mention of whether or not the child has had a vaccine. And so if you're following these guidelines, you are meant to do a blood test in every child under 3 months of age. And if you're worried about them, then you do a lumbar puncture if they're under 1 month or if they look especially unwell. So this created a potential that we were going to get lots and lots of children coming into accident emergency with fever and trying to manage that. Now, mindful of that, the Public Health England put out guidance such as this, such as we've been hearing about, saying give prophylactic paracetamol, we know this reduces your fever rates, everything should be good. But we were still very interested in what was going on. And so this is a project that was undertaken as a service evaluation, so an audit effectively, at those 2 hospitals, John Radcliffe and Banbury, by a medical student from Monash University in Melbourne, who wanted something interesting to look at and said, this is what's interesting. And so she manually looked, scanned all the electronic records of every patient between 1 and 6 months of age who presented with fever or irritability or a non-specific presentation from September 2013 through to September 2016. So that's 2 years before the MenB vaccine was introduced and 1 year after the MenB vaccine was introduced. And she filtered them down, you can't see the details, through a cascade of questions that we devised to try and work out, was this a probable vaccine reaction or was this a possible vaccine reaction? Probable means the clinician thought it was a vaccine reaction. That's what it was coded as when the child went home. This was a child who had a fever, there was no definite other cause, it was within 48 hours of immunisation, so it could have been a vaccine reaction, even though if the clinician wasn't convinced. And then we had the vast majority that were not related to immunisation. Either they weren't within 48 hours of immunisation or a clear alternative cause was found. And so we were able to go through, for that 3-year period before and after the MenB vaccine introduction, to look to the numbers of children presenting with either possible or probable vaccine reactions to those accident emergency departments. And we used as a control the children presenting with urinary tract infections, because we know more children are coming into emergency with changes in primary care practice. So we wanted a control condition. So this is over the 3 years, and so in the dark blue lines we have the presentations for vaccine reactions with a big jump in number of cases from before to after, with no real significant change in the number of urinary tract infections. So that was our starting point to say, well, it does look like there's something going on here. And just in terms of the total number of cases, to keep this in perspective, that's 37 cases. So just under 1 a week for that, between 1 every week or 1 every 2 weeks for that year period. You're getting a child coming in through accident emergency. So not overwhelming accident emergency, but potentially an increase. We wanted to dig a little bit deeper and understand that a bit better. So we were able to split them down into what immunisation episode was this? Was it just at the episodes where the MenB vaccine was given, or was it across all 3 infant immunisation episodes? And yes, it was just when they were getting the MenB vaccine. So we saw an increase, a 3-fold increase in 2-month-olds presenting to accident emergency with fever, irritability, any cause, before to after MenB. No significant difference at 3 months when they're not getting the MenB vaccine, and again an increase at 4 months when they are. This is an 8-fold increase at 4 months, but obviously the overall numbers are lower. And when you add it all together, approximately it's a 4-fold increase at these 2 immunisation episodes. So there has been an increase. The question is, to some extent, does it matter? The other question is, what happens to these children? Actually, and just to summarise that, it's gone from before MenB to presenting to A&E. You had a presentation for every 972 doses for 2-month-olds. Now it's 1 in 295. And at 4 months, it's gone from 1 in 7,000 to 1 in 800. So very low. That 1 in 295, that gets you thinking a little bit. So that's about, so let's say 1 in every 300. If 600,000 children are being immunised every year in England, that's about 2,000 children presenting to accident and emergency with immunisation fevers if you scale that up. In terms of what happens to these children, in the MenB era, 70% of them get admitted to hospital. Just over a third get blood tests, and just under a quarter get lumbar punctures. But they are looking sick enough, and this has gone up from 40% to 70% getting admitted to hospital. That might be a local effect because we have opened a clinical decision unit which has grown in capacity during that period of time, so that's a 24-hour observation ward. So there may be a little bias there. But it's still impressive, actually, I think notable that 70% are having an overnight admission if they get through the doors of the emergency department. And this shows this broken down, and actually what we're able to do, and what I didn't explain is that we are determining the rates per dose by looking at because those two hospitals serve all of Oxfordshire and not so much the surrounding counties. So it's reasonably tightly geographically linked to Oxfordshire. We were looking at the denominator here, the total number of doses of these vaccines being given in Oxfordshire, and the Child Health Computer Department's kindly provided that to us. So again, we're able to look at rates per 1,000 doses here, which has gone up in terms of admissions to the ward, admissions to the clinical decision unit, lumbar punctures, venipuncture, antibiotics. All of these are statistically significant increases that we are seeing. This does not undo the great work of the MenB vaccine, the impact on disease. These are transient effects that are not in themselves harmful. Parents won't be thrilled if their child has had a lumbar puncture because of a vaccine reaction, but they're not in themselves harmful. As I say, we need to keep reviewing this in the context of reduction of MenB disease. But I think there is work to be done here to see if this is an ongoing phenomenon or if this was just a blip, and that GPs have got more used to it and they'll be able to manage it in primary care more, and so we hope to be doing this. We need to know if this is happening around the 12-month immunisation, because so far we've only looked at 2 and 4 months. We're going to establish, we're going to be looking at a case control study, which we would like to get going at the moment, to look to see for these children that present to accident and emergency, to go back to the GP surgeries and ask, you know, for other children immunised that day, what proportion of the children that presented had paracetamol versus what proportion in the same surgery had paracetamol, to see, and that would give us a true idea if paracetamol reduces your risk of presenting to accident and emergency. And if it does, that needs to be pushed more, perhaps, and then we might be able to reduce this. And will give us an idea of the overall uptake in the community as well. And I think perhaps we need to look at developing adapted guidelines for management of post-immunisation fevers in accident emergency in the MenB era to see if we can perhaps reduce the number of invasive investigations or better distinguish those children with bacterial sepsis versus those with post-immunisation fever. So this work has been going on from, as I said, a medical student who came, and she's been followed up by Nida, who is somewhere here in the audience, who's going to be carrying on this work for the next year. Jim Buttry, some of you may remember, worked at the Oxford Vaccine Group years ago, and he's actually helping, inputting on this from Melbourne. And Sally, who's one of the A&E nurses, who's helped us with this as well. So that's where we are. Any questions?